The very last thing we have here are the nerves that carry all this information out to an effector, right? My cranial nerves and my spinal nerves. These are peripheral nervous system. The nerves that arise directly from the nuclei that come off the brain, any part of the brain, these are cranial nerves. There are 12 of them. Most of them are mixed, which means that they carry both sensory and motor. Some are somatic. Some are parasympathetic in nature. Okay? And these are, as you can kind of see, associated with a number of things that happen in the head. Pretty easy stuff. There's some special senses in here. Vision, olfaction, hearing, along with general types of sensation, touch and whatnot on the face. Here are your 12 cranial nerves: olfactory, optic, ocular, motor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and hypoglossal. Okay. On old Olympus's towering tops, a famous vocal German viewed a hop. That's the mnemonic to remember. That's the best mnemonic to remember. Okay. What's its function? And by that, I mean sensory, motor, or both. Obviously, this is not very specific. Some say Marilyn Monroe, but my brother says Bridget Bardot. Sensory, motor, both. So that's both sensory and motor. Motor, both. Sensory, both, motor. Okay. Olfactory is the special sense of smell. Okay. That's going to be the nerve that carries that information back. Optic nerve is involved with peripheral vision. Okay. So have the person look straight ahead. Can you see my finger? Tell me when you can see my finger. Yes. Is it moving? No. Yes. Okay. That's optic nerve. Ocular motor is involved with the cardinal fields of gaze. When you have the patient kind of, okay, focus on the tip of my pen here and just keep your head straight and follow with your eyes. This is the cardinal fields of gaze, triggering every single nerve or nerve muscle associated with eye movement there. As you can kind of see, trochlear is also involved with this. As you can also see, abducens is involved with this. Okay, those are the three muscles associated with the extraocular eye muscles: LR6, SO4, R3. Lateral rectus is by cranial nerve 6. Superior oblique, supplied by cranial nerve 4. And the rest are supplied by 3. So ocular motor obviously is motor command to the extraocular eye muscles, everybody but superior oblique and lateral rectus. And again, these are all the muscles that attach into that sclera of the eye. Accommodation is when you have the patient just watch the thing come in, the pointer come in, and their eyes will converge. Okay, it should move equally. If it doesn't, then there's some issue potentially. Trigeminal, it is both sensory and motor. It's to the muscles of mastication, so that's why you bite down. The masseter muscle, the temporalis muscle, you'll feel nice and robust evenly on both sides. Corneal reflex, again, it's sensory to the face. So you take a Kleenex tip, have them look up into the corner of the room and touch the white of their eye. Sensory information from the face. Abducens, we already talked about it. Facial is the motor to the face. So have them smile. Should be nice and equal on both sides. Puff out the cheeks. Vestibulocochlear is going to be involved with hearing, equilibrium. We test hearing when it comes to this. We don't generally test equilibrium in the office unless that's their specific issue. So to do that, you do a Weber-Renes test. And do I have? Let me look here. Found it. My tuning fork. Let's see. There it is. There it is. My tuning fork. So with Weber's René, you strum it. Okay. And then you basically put it atop the head or right in front here on the kind of bridge of the nose, or I put it on top of the head. Okay. And then you ask them, can you hear it? Yes. Do you hear it better on one side or the other? If they say no, perfect. That's what they're supposed to hear. That's what you're supposed to have. Hearing it equally on both sides when it's right smack dab in the middle. If you hear it more on one side or the other, then that could indicate some potential issues, whether or not it's conductive issue or a central neural issue. We'll talk about that when we look at the ear in the special senses or in the senses lecture. Then you do the next test, Renee's test. With Renee's test, again, strum it, okay? And then you put the tip of it, without touching anything, put the tip of it right on that mastoid bone, okay? And you time in this thing. And then, can you hear it? Yes. Tell me when you can't. Note the time, and then bring it right in front of their ear. And they'll still hear it. And then tell me when you don't. Time. There is a ratio. If you hear it longer with bone conduction, so touching that mastoid bone on Renee's, then you know it is it's a conduction issue, okay? Or sorry. Sorry, phone went off there. If you hear it more in front of your ear, then you know that it is a conductive issue. Okay. If you hear it a heck of a lot longer during bone conduction, then you know it's a potential neural issue. So there is some fun things that you can kind of figure out from Weber and Renee's, whether it's centroneural issue or a conduction. Does the sound wave conduct through the nerve or conduct through the pathway, through the external auditory meatus, through the eardrum, malleus incustapes, to the cochlea? Okay. If there's a conduction problem, then otitis media, ruptured eardrum, all those fun different things. For glossopharyngeal there, you can do the gag reflex. It works on the uvula back there, so take your tongue depressor and jam it down the back of their throat. The patient should gag. If you just have them open up and say ah and look back there at the uvula, it actually deviates away from the affected side. The weak side, if the uvula is coming down here and it goes away from the affected side, that means the muscles up there in the soft palate and whatnot, where the uvula hangs down, are really weak. So the side that's receiving sensory or motor input, it actually engages and pulls the uvula to that side. Vagus swallow. So put your hands on either side of the larynx there and have the patient swallow. Should go up and down equally. If one side goes up followed by the next, then you know there's a potential issue. Accessory used to be called spinal accessory, but now it's just called accessory. It goes and supplies the trapezius and the sternocleidomastoid muscles. So, put your hands on the patient's shoulders and have them raise against resistance. Have them look down and away against resistance. Test the SCM. And then hypoglossal, stick the tongue out. If they stick the tongue out and it goes winging off to the side, that tells you that it's going towards the affected side. Again, the tongue is skeletal muscle. So if it's not receiving innervation, then the muscle starts to atrophy. So if it points to the affected side, as the tongue comes out, when it comes winging off to the side, that means this left side is really strong and this right side is really weak. When would you see these things, everybody? With head trauma. Okay, with head trauma. So if there's swelling in the cranial vault, you will see all these fun different things manifest, and they go away when the swelling within the cranial vault goes away. So any type of head injury, whiplash, this is when you'll see some of these things manifest. Am I going to ask you how to specifically test it? No, all the stuff you've had before. Okay, so can I ask, what does the olfactory nerve do? Well, it's involved with smell. What is facial involved with? Muscles of the face. Okay. What is the trigeminal nerve? Sensory to the face, muscles of mastication. So there's no short answer questions. I may have a handful of multiple choice type questions, not a whole heck of a lot. Last thing we have here are spinal nerves. Spinal nerves, again, part of the peripheral nervous system. They arise from the spinal cord and extend out into the periphery. You have 31 pairs of these suckers. These are all mixed nerves, which compared to the cranial nerves, where some were and some were not. 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 to 2 coccygeal. This one says 1, so we'll ride with it. Okay. Can somebody have more coccygeal nerves? Yes, somewhat common. Okay. There's a little bit of variation, but that's normal there. Again, they all are a mix of sensory and motor. They carry it all out. Okay. We can test motor for some of these. We can test sensory for all of these. All of these nerves give off a supply that goes to the skin. So we can test the sensory component of all of these cranial nerves, or I'm sorry, all of these spinal nerves. So you take a pin and you touch out here on the arm, and it's testing C5, testing this the 5th cervical nerve root. Compare it to the other side. Does it feel the same? Compare it to other dermatomes within that same side. Is it more, less, the same? Again, this allows you to figure out, is it an upper motor neuron lesion or is it a lower motor neuron lesion? Okay. And again, cervical plexus. The biggest one there was the phrenic nerve, right? Phrenic nerve. Phrenic nerve goes to the diaphragm. C345 keeps the diaphragm alive. The brachial plexus, this C5 to T1, radial nerve, ulnar nerve, median nerve, some of the big ones there, ulnar nerve, brachial, all those fantastic things. Lumbosacral plexus involves various different, the sciatic nerve, the femoral nerve. Sciatic nerve gives rise to the tibial nerve, common peroneal nerve, or common fibular nerve, sorry. Okay. So a bunch of fun different nerves there, all right? And we'll talk about maybe some of these more bigger nerves when we get into it. Do I want you to know that the phrenic nerve is associated with the cervical plexus, or what's nerves associated with the brachial? I may ask a question or two, but you've already gotten that information. That's your prereq for this class. So you should probably already remember that, all right? What I would ask maybe is, how many cervical spinal nerves are there? Thoracic, something like that. Okay. Ventral roots give rise to all these plexuses over here. All right. And you can see, oh, look, they give you some examples of some peripheral nerves. Ulnar, median, radial, femoral, sciatic, lateral femoral cutaneous nerve. There you go. Phrenic nerve. I gave you another one. Okay. Sciatic, lateral femoral cutaneous, femoral nerve. All of those come from the lumbosacral plexus. Ulnar, median, radial. All those come from the brachial plexus. Phrenic nerve comes from the cervical plexus. I expect you guys to already know that. So you may see a question or two based on that. Last thing we have here is reflexes. Reflexes is just unconscious motor control. Okay. Unconscious motor control. Again, these are going out to skeletal muscles. Skeletal muscles are inherently voluntary, but I can trigger them with a nice big fat whack of my reflex hammer. To have a reflex arc, I need, number one, a sensory receptor. A sensory nerve. I may or may not need this, okay? Some reflexes have an interneuron, some do not, okay? If I do have an interneuron, it's referred to as polysynaptic reflex, and it takes a few fractions of a second longer. If That sensory neuron synapses directly on the motor neuron, which I have right here. Okay. Then it's monosynaptic and it happens faster. And then lastly, I need an effector. So there's 5 general things that you need, or 4, depending upon polysynaptic or monosynaptic. All right. These are generally what we test when we are looking at reflexes. And certain reflexes are fantastic because they can test the integrity of the nervous system. Here are some. Somatic are the only ones that we really worry ourselves with testing anyway, in an office setting. This is the corneal reflex that I just briefly explained. Biceps tendon reflex, patellar, Achilles, umbilical reflex. Good gosh almighty, there's a whole handful of them out there. And some of them are great. The cremasteric reflex. Okay, stroke the inner thigh, the testicle rises on that side. Okay, there are certain ones that you can hallmark, fantastically test, and test for specific nerve roots and test the integrity of the spinal cord in the same process.